Let's finish this section up. I'm going to through some of this a little bit more briefly. The one that I want you to concentrate in the next 20 minutes that I'm going to talk to is about PE, but we'll get to that in a minute. The first thing we'll talk about is acute arterial-occlusive disease. This disease process has actually gotten much easier to manage than in the past. It's usually due to an embolic source coming usually from the heart. The most common cause from that is from a post-MI where you have a thrombotic component or you have atrial fibrillation and then the heart throws emboli out of the heart down to the peripheral extremities. Okay? You can also see it in prosthetic heart valves. You can also see it from vegetation from infective endocarditis and also from tumors such as atrial myxomas. So you can see these embolizations that take place and acutely occlude the peripheral arteries, causing a sharp demarcation to take place, and you know that the artery is completely occluded. The nice thing about it is in the old days we'd have to go to the operating room and have to surgically open up these arteries and repair them. The present-day therapy, on the other hand, is much easier. It involves putting a catheter in usually the contralateral side that's not affected, feeding the catheter in, putting it up against the area where it's completely clotted, and then giving thrombolytic therapy. So it's much more effective, much easier for the patient, and it doesn't destroy the architecture of the artery. So these people don't get reoccurrence of disease just because they tend to form thrombus from the vascular repair. So in that sense, it's much better that we treat it with this new radiological method that we have. Signs and symptoms that you see with acute vascular is signs of sharp demarcation and color changes. You literally can feel where the artery is completely occluded. Just run your hand down the leg, and all of a sudden you feel it from being warm to cold. You can pretty much tell that's where the artery is occluded. So if you feel it below the knee, it's popliteal. If you feel it above, right below the inguinal area, most likely it's the femoral artery or the iliac artery that's been occluded. The skin feels cool. It's very easy to pick up, and then you tend not to have any distal pulses after that area. It causes severe ischemic pain, and if it doesn't get better, may cause infarction of the muscle, developing to rhabdo and development of compartment syndrome. Okay, the compartment syndromes can be extremely difficult to treat, where you actually have to go in there and actually do a sclerotomies and open up the skin to actually drain out the blood decrease the swelling to take place. Treatment is a good thing is radiologically now. Surgically it's become a minor issue. Now we use Fogarty catheters. In the past we'd put the Fogarties directly and then pull back the clot. These new thrombolytic therapies are much more effective and they have a less or a problem. The only problem is that we have to come in and sedate the patients at 1 o'clock in the morning down in radiology. But otherwise, I prefer doing that any day of the week than having to go surgically take these people back at 2 o'clock in the morning and then sitting there for 4 or 5 hours while the surgeon's putting in these catheters, and he's basically guessing where the clot is at. Versus radiologically, they're not guessing. They can see it, and then they inject the thrombolytics directly to it, and within a few hours, the person is all better. So it seems to be a much better way of doing it. You have also chronic arterial-occlusive disease. It's usually almost always due to atherosclerosis, and basically what you see is a plaque formation within the major artery, eventually completely occluding the artery, which then causes significant problems. Okay? I'm not going to go into chronic occlusive disease too much because it's just something you should know about to a certain degree. It's very similar to acute. The difference is it just comes on more slowly. It's not as responsive to thrombolytic therapy, but it is still because most of the time you get acute events due to a plaque breaking and then causes thrombus to form. Venous thrombus formation is a big problem in the hospitals because surgery makes people static. Okay? So as a consequence, there's an increased risk for developing DVTs in patients. When you have DVTs, what increases the risk? Patient has surgical procedures, pregnancy, congestive heart failure, MI, anything that decreases blood flow to the legs or decreased perfusion, such as congestive heart failure or MI, increases the risk. You have abnormalities of the venous wall, such as varicose veins or drug-induced irritation, or you have altered coagulation states like oral contraceptives or carcinoma. So the other thing is the predisposing factors of orthopedic procedures, such as hip surgery or knee reconstruction, all these increase the risk of developing DVT formation. Morbidly obesity and elderly. Now look, this is the perfect storm, okay? You're having people that are elderly who you're doing these joints replacements on, and they're all morbidly obese because that's why their joints failed on them, okay? So what do you think the chances of them getting DVT? It's very, very high, A lot of people die in hospitals, not from the procedure itself, but they die from the complications of DVT formations. Signs and symptoms are usually they complain of throbbing pain. They can get cord-like structures and palpation. After 25 years of doing medicine, I've never felt a cord yet. So I don't know what they're talking about. Okay? They say it everywhere in the books, and every time I look for it, I don't feel it. Okay? When somebody told me the other day, said, well, I can feel one, I went and felt it. I couldn't feel it. I don't know what they're talking about. They don't feel like cords. So, you know, and end up finding when we did the ultrasound, the guy didn't have a DVT at all. So much for what he was feeling, you know. Edema may also be usually associated with, because you get venous congestion, and you get associated muscle spasms, you get decreased perfusion, and as well as vascular congestion around the muscle itself. The best diagnosis is using ultrasonography, especially in new ultrasonography. The torturous method is to do venography. Venography is really not happy. You only get one person to do a venography once, and they'll never do it again. They'll put a nice IV in their periphery and then inject dye into it and watch the people scream. Okay? Because veins are pretty painful when it involves putting dye in them. So you might get it done once, but that's the last time they'll ever do it. The new way of actually diagnosing this is rapid spiral CT, which actually picks up the pelvic DVTs, which are not done very well with ultrasound. So that's the new gold standard. So a lot of things are being picked up that we did not appear before. This is what's called varicose veins. Not that they're very close, it's just that they're dilated and the valves are actually malfunctioning. These people do not have, this is superficial, so it's not a problem for increasing risk of DVT. Okay? They will form superficial venous thrombosis, yes, but the chance of that actually embolizing is pretty low. The ones you have to worry about are the ones that have this kind of problem internally in their pelvis. So women that are pregnant, that have engorged pelvic veins because of the uterus actually compressing on the vein return, will increase the risk of developing DVTs, deep venous thrombosis. Okay? Compression stockings help, and anticoagulation is always indicated in these people to reduce the risk. Okay? If you don't have somebody who can tolerate anticoagulation, then you need to consider IVC filter formation. And this is what an IVC filter looks like. Okay? And this IVC filter is a green fill filter, and you will see in this picture it actually has a clot inside of it. Okay? So this person has thrown a DVT, and it's basically getting caught up by the IVC filter. Now, IVC filters are important for us for two reasons. One is you have to know that they exist. A lot of patients don't know they have them, okay, because a lot of times they were in the ICU sick, and then they had an IVC filter put in them, and they just never were told. Or they were told, but they don't remember. Okay? The problem with it is it's located in the inferior vena cava, and if you're silly and you don't do what I tell you to do, which is don't put the wire beyond 20 centimeters, I'll get a phone call at 3 o'clock in the morning like I did a few years ago. And the person who was putting in this central line said, I can't pull the wire out. And I said, really? He says, so what's wrong? I can't figure it out. He says, here's what you do. Most likely you're on IVC filter, and the other person on the other side of the phone says, no way, that can't happen. I said, okay, just get an x-ray of the abdomen, and you'll see that the wire's stuck on the IVC filter. Sure enough, that's what it was. Okay? If you put the wire beyond 20 centimeters, and it's this catheter, this thing is located right in the IVC filter, the J-loop grabs onto it, and you can't get it out. Okay? The ones that have tried to do it by Brutane, which means no brains and all strength. Okay? One person ripped the inferior vena cava and killed the patient on the spot. And the other person that did the same Brutane that was put on the news in the actual literature pulled the IVC filter all the way back into the right atrium and right ventricle. That was not a good day, both of them, okay? So don't do that. And what you do is you call your friendly radiologist, is what I told him. And of course, the radiologist is going to love you to wake him up at 3:30 in the morning. He's going to be all happy to come and see you, so he's going to come in and give you a hug. Yeah, right. Leave that. There's more tales I can give you. Okay? Well, what they do is they come in. They're usually not pretty happy at all. They prep the wire into a sterile field, which is already there. If you keep your sterile field up. They'll put a plastic cannula over the wire, and they'll feed the plastic cannula down the wire until they reach the area where the J-loop is at. And then they'll just push the plastic catheter, and the J-loop will come out of it, and then they just pull it all out. So it actually has no effect on the IVC filter at all, and the patient does fine. Okay? So don't panic. That's the name of the game. and then let them put the central line over the wire since they're already there. So they can get the procedure bill for it, okay? That's the way it goes. So if you don't put in the 20 centimeters, you won't get into, if you don't get beyond 20 centimeters, you'll never get into this problem, so it's not an issue. Be careful that some people do have SVC filters. Do not put a central line in those people unless you have a radiologist with you, and not a smart move. And if you do that, you will catch the IVC, superior vena cava filter, and cause all sorts of problems. So I don't recommend putting a central line in those people. PE is the last thing we're going to talk about, and PE is a real problem for us, and it's very scary. What you see is pulmonary embolus. It's like throwing a hand grenade into the lung. By that I mean that as the embolus comes up to the lung, as soon as it comes into the pulmonary artery, it blows up and doesn't stay into one fragment. It fragments into millions of little pieces, and it goes to high blood flow areas. So where does most PEs go? Right lower lobe, okay? But it does go everywhere, but it tends to go preferentially to the right and left lower lobes, especially more right because higher blood flow, 60-40, going to the right, okay? You get immediate increase in alveolar dead space, bronchospasm, decrease in surfactant production over the next 6 to 8 hours, significant worsening of atelectasis, decreased pulmonary compliance. Airway resistance goes right to the roof. Arterial hypoxemia is usually very evident because of a huge VQ mismatch, because you're no longer adequately perfusing areas that are receiving oxygen. Tissue necrosis may develop, and you may actually get a very acute increase in PVR resulting in right ventricular failure. If you get what's called a saddle embolus, the right ventricle will completely fail and the person's dead right on the spot. Okay? So if you can survive the first 15 minutes of supportive therapy, then usually most people survive a PE. It's the first 15 minutes that's critical. Symptoms can be very symptomatic, or they usually complain of severe shortness of breath. They'll tell you right away, I can't breathe, or I can't seem to get air in me. That's usually a very typical sign of a PE, okay? Especially if a person's going from a recumbent position to a sitting position or standing up, that's when the PE gets thrown. So that's when you usually see these kind of symptoms. I had an 18-year-old boy that died on me one day right in front of my face from a fat embolus, from a femur fracture. We had moved him from his bed and moved him over to a chair. And moving him from the chair, he threw a massive fat embolus, and he told us immediately, I can't breathe, and he went out, and that was it. Never got him back. On autopsy, they found the boy had a complete occlusion of both. He had a complete saddle embolus with fat. Completely killed him. So things can be really, really bad. You'd be surprised. Rales tachycardia may be evident. It's usually always seen because you have a limited stroke volume getting to the left ventricle. Fever is a very later sign, and because of the clot that forms, and you tend to get hemoptysis at times. This is where the PE tends to go to the right side, which is what I was showing you before. EKG is a really poor indicator, so I'm not going to talk about that. You may also get a pulmonary infarct. This is what a pulmonary infarct looks like. This, of course, is not done on somebody who's alive. This is a pathological specimen since this person died from the PE. Okay, this is what actually an infarct looks like. You can see the wedge resection. This is all the blood supply to that lung is basically gone. As a consequence, that area became necrosed, and the person developed severe cough, hemoptysis, and fluid chest pain. If you do have a problem with the PE during anesthesia, the trick is to maintain adequate oxygenation. They get severely hypotensive, okay, because they have a limited stroke volume, limited amount of volume back to the left ventricle. So they invariably get tachycardic. This is not the time to try to slow down the heart rate. You want to give them more volume to dilute out the clot, okay, and you want to get some continuous perfusion going to the left side. Now, a lot of times you have to give catecholamines to maintain their elevated heart rate and increasing the blood pressure. So sometimes you give dopamine or epinephrine may be necessary to prevent this from going to terminal states. Bronchospasm is very always evident. Don't be surprised because the clot usually causes an anaphylactoid-like reaction, and you see an acute drop in end-tidal CO2. Okay? When you look at the actual lab diagnosis, everything pretty much doesn't help. BNP levels may be elevated. The other thing that you see is split, what's it called? Fibrin split products are also elevated with this, but they're not enough to be indicative of this disease. This shows you the PE on this another pathological specimen showing the clot inside the arteries of the lung. Definitive diagnosis is by VQ scan or by pulmonary angiography. Okay? These are high-risk procedures, to say the least, when these people are critically ill. What I want you to know is what happens with end-tidal CO2. This is the normal end-tidal CO2. What you see with a person with acute PE is that you'll see this curve go from this to all of a sudden do this. Yeah, an acute drop within one respiration. It goes from 36, 36, and it goes to 24. And if you're in really bad shape, if it's a saddle embolus, it'll go to 12, and then you'll go down to 4, and the person will be dead. Okay, so end-tidal CO2 indicates to you perfusion to the lung. Okay, if you lose your end-tidal CO2 like that, the patient's dead. You're never going to get him back because it's a saddle embolus. The only way to keep that person alive is open up their chest and actually go into the pulmonary artery and remove the clot. The likelihood of you getting there fast enough is 0. Okay, I've seen it tried. I've seen it tried while we were actually doing something in the operating room, and every time I've seen it tried, it failed. I mean, we got in there and pulled the clot out, but everybody was brain dead. Okay, it just takes too long to get there. Okay, so the trick is if you see this acute drop, then make the surgeon aware that it's got an embolus. Immediately flood the field. If it's an air embolus, immediately flood the patient with volume. And the reason you open up your IVs wide open is because you want to basically dilute out the clot as quickly as you can. Okay. Maintain support, call for help immediately. You are going to call for help. This happened to me when I was actually talking to students at the library downtown. Some of the students came over to talk about PEs, and we were just sitting there and talking about it. And we had a massive PE from cement while I was talking to them. So the students came over and got to see it real live. It's kind of interesting, to say the least. One of those weird freak things that happens in life. Treatment was supportive. Systemic anticoagulation is considered very early because that's the only way you can actually break up the clot. Sometimes thrombolytic therapy is a consideration. The problem is usually when you're doing operative procedures, guess what? Thrombolytics are really not going to be a good idea. The person then exsanguinates from the actual surgical procedure. So be careful with that. Management, FiO2, 100%, supportive, and keep fluids going. The last thing we'll talk about is fat embolus, and that's usually what I just talked to you about. It's associated with long bone fractures. The way you can differentiate with this is look at a petechial rash in the upper extremities, and that's how you can pick it up.